Hi everyone, this is Neil Writer, consultant audiologist and director of ClearX. Thank you for joining me in this really complex and interesting case. It's a bit of an unusual one, and it's actually of a patient who attended today, and I thought I'll get it uploaded for you guys straight away. I'll give you the patient's history and case summary. So they first visited me, I think 2022, and the reason for that first visit was that they underwent earwax removal at another clinic. And now this patient, even back then, wasn't local to me, but they were about an hour away. And they visited a couple of specialists nearby. And the second one in particular, they weren't pleased with. They attempted microsuction, wasn't successful, but it is a very difficult case. So I'm not saying it in the sense where they should have removed it and they didn't. But what really upset the patient after that was that the clinician who they saw attempted ear irrigation. That wasn't the issue. Well, it partly was because they developed otitis externa as a result after that. But I mean, there is always a risk of that, and that's why I always avoid irrigation. I was going to say where possible, but I've never performed irrigation apart from undergoing some training several years ago. But they weren't too pleased with the hygiene surrounding their irrigation. They were given a towel that was really dirty and filthy. I might have, when I uploaded this patient's original video, I might have mentioned that. I do recall mentioning that in a video a few years ago. So after that, they came to myself, and it's always this their right ear. And there's two major issues. First of all, the entrance, as you can see, is so narrow. Even once you get in, the ear canal itself is a lot narrower than usual. But that, it's fine. We can deal with that. But the main issue is the consistency of this wax and skin. It's a bit combination. And it's like caramel. And if it was in kind of a blob of caramel under the ear canal, fine. But this is just lining the ear canal and eardrum. And for me, this was possibly so far the most challenging case I've done this year. And as a viewer, I totally understand that. You may not think, how can you say this is the most challenging one? Because I've done a few recently that I've uploaded, or at least since the beginning of the year. And I think it's when you perform it, there's so much nuances when you perform a procedure. It's only when you perform it yourself you kind of realise. I've done the grade 3 keratosis obturans recently, but although that was challenging, this was far more. And the reason being is it's not only because it's a caramel consistency, which is really, really difficult to suction, but it's sitting right on the canal wall, the entire ear canal, and also their eardrum. And it just wasn't vacuuming. Can't use any other instruments for this. Of course, you can't use an ear hook or forceps. Even with the Rai-Correct, this patient's also got very sensitive ears. They've got very narrow ear canals as well. And it's so strongly adhered, it's going to be very difficult to use the Correct to kind of glide in between. So this just had to be done with suction, and again, not with water, because this patient's previously undergone irrigation, which led to an ear infection. But irrigation isn't going to remove this. This is so strongly adhered to the canal. Now, you can see there's a sheet of skin there, and I was hoping the eardrum was, once I removed that sheet, the eardrum would be visible, but it wasn't. So this is that sheet of skin, and I'm just trying to tease it away. To continue with the patient history, so I saw them back then, and then we treated the patient back in 2022. Then they used to come every, I think, 9 or so months. But for the last year, this patient has moved to London, in South London, which is 3 hours away. And it's just been so difficult. It's a long journey. It's 6 hours return. So this patient decided to see if they could find some local specialists to treat their ear. And over the last few weeks, they visited a couple of places, and again, I totally understand. They just said it was just too complex, because as they were trying to peel this away, it was becoming uncomfortable for the patient. And both specialists kind of know of me, and they said, you just probably best just to return to Neil I know it's a long drive, but they just didn't want to risk it continuing any further because they were causing some discomfort. So patient travel today. Now, with this patient, normally our appointment slots are half an hour, but I know this is going to be complex, so we've got a note on file just to allocate a bit more time. In total, there, right here, it took about 45 minutes. The 13-minute edits of parts when I'm out the ear, unblocking the tube because the suction tube kept getting blocked. And also we put loads of drops in at various intervals. So all those parts I've edited out, but otherwise you're seeing the full unedited video. So this is I think this is a 16 gauge at the moment. So it's slightly smaller. But it's taking up a lot of the space in the ear canal. And when you're peeling skin like this with a caramel consistency, you do need to have some leverage, but that was restricted because I can't maneuver the suction probe too much, because if I do, it's going to hit the opposite side of the ear canal. So again, I've just put some more drops in. Another challenging thing with this is every time I put drops in, because the ear canal is so narrow, even though we've dried it out, when you put the endoscope in, because there's a few hairs there as well, it's just slightly obscuring the lens on a couple of occasions. So at this stage, although I've cleared quite a lot and the eardrum is in the distance, the patient still wasn't able to hear. And with this caramel type of consistency, it's different to dry skin. With dry skin, as you start peeling it, there's something to grab onto and it starts to peel as a sheet. Here, just when you think you're going to get a nice long peel, the caramel consistency of skin, it just cuts away. So then you have to start again, find a section on the ear canal that you can grab onto. On some occasions, you'll see it as we progress through. There was nothing for me to latch onto. Normally with drier skin, the tail end of it's sticking up and you can get a good suction grip. But here I had to generate my own leverage, which means working really, really close to the canal wall. And if it's on the cartilage portion, it's not so much of an issue. But when you're on the eardrum directly and also the bony part of the ear canal, the inner 2/3, there's no real margin for error. So this is some skin at the entrance here. This is, I mentioned as I was inserting the endoscope to stretch the ear open, because this ear canal is completely narrow at the entrance. I'm having to use the left-hand side of the endoscope to push open the first bend. You can see a few hairs protruding. So I just wanted to clear that region a little bit so it's not obscuring the lens. So although sound can travel through the ear canal to the eardrum, because the ear canal itself is unoccluded, it's just the peripheral walls of the ear canal, you've got this consistency lacquered over the eardrum as well. And I was kind of dreading it, partly removing that. So what was going through my mind was, let's try and peel the canal, and then hopefully as it starts to peel, as we approach the eardrum, it will also then come away from the eardrum. But it didn't necessarily work out that way. And when you've got a layer like this of caramel skin on the ear canal, you just don't know how thick it is. So therefore you've got to be really careful, because if you misjudge the thickness of the skin, you're just going to bump into the ear canal and it's going to be really uncomfortable. So I'm just peeling this from the anterior canal wall. So again, just dilating open the ear canal. There's a little bit here that's lifted up, so I'm going to use that as the traction to get the suction grip and peel forwards. And you can see it just cut away. I was hoping as I was continuing that skin would continue to peel, but it didn't. It just cut away, and I would have to start that area again. So just gone back to the back part. So again, this looks promising at the moment. I'm thinking the skin is flapping, it's loose. So if I can peel this and then go towards the eardrum. Hopefully it will come away in a sheet, but this skin wanted to peel backwards. So sometimes with skin, as you start peeling it, you can go towards the eardrum. But with this piece of skin, as I was going forwards, it wasn't peeling. So I had to come back. But it's not a problem because it's helping me clearing the entrance. Although the main thing at the moment is to get the eardrum clear. And typically I do try and remove wax, debris, whatever it may be off the eardrum, or at least from the centre of the ear canal, so sound can travel through to the eardrum. That's my normal route, but here I'm going to clean this anyway. So as I'm here, it's coming away, so it's just so sticky. But I'm getting some purchase here, so I'm going to lift it off the canal. I think it just blocked the suction probe. Going to give it a little wriggle outside of the ear. Whenever your suction tube is blocked, ideally you want to come out the ear, because sometimes it can unblock itself, and as it does, the wax shoots up the suction tube. It slurps up it, and it can be quite noisy. Probably something I was guilty of originally, and then you get into a habit. It's very difficult to break habits actually when you're doing earwax removal. But I think I've rewired myself, so whenever it's blocked, now sometimes you just know it's going to unblock, and by the time you come out the ear, it's going to unblock. So you still try and come out so the noise is a further distance away from the eardrum. So the eardrum is there in the distance, but you can't see the landmarks. A spoiler alert, there's going to be a little bit left. But I was really pleased with how much I was able to remove. There was parts in the procedure where I thought I just don't think it's going to come away. In recent videos, I've been accused, and I'm just pointing this out. It doesn't really bother me, but thought I'll make reference to it, of prolonging procedures on purpose to get views. Now, just to give you some insight, tomorrow I've got a Clearwax training course, and we need to set up the room, and our business development manager for Clearwax finishes at 2:30 today. So the plan was this afternoon, I was giving myself, not afternoon off, but catching up with loads of admin, and whilst I'm doing that, she can set up the room, which can take up to 45 minutes really to set up. But because this procedure was longer, although I allocated a bit more time, I actually ate into that time and then into my lunch when the room was started to be set up. In any case, we finished late, so my business development manager who sets up the room had to stay behind to set up the room. So certainly we don't prolong procedures intentionally, especially when we've got other things to do and it's a patient's ear. We don't want to overexpose them to the suction, for example. But that is the world of social media, unfortunately. So I've got the outer half more or less away. I'm just looking for a region. Now this bit looks promising because I can see the canal wall to the left and we can see some skin there. So I've got something to hold on to, but it was just flaking away. Again, I'm just going to stretch open the ear. I'm just looking for a good place. So there's a bit at the bottom there you can see, and there's a bit to the back here. So I'm just really zooming in. As I'm getting suction grip, I'm trying to peel away. You can see that is quite a thin layer. So if I misjudged that, I would have poked right into the canal wall, which would be uncomfortable. And again, I'm thinking to myself, brilliant, I've got this piece of skin and I can start peeling and it's all going to come away. But as we approach the eardrum, it just cuts away. So I think here I'm using the 18 gauge suction probe. So I've gone to this bit here where it was sticking up. Now normally with dry skin, that will just start to peel without any problems, but here I'm really having to work for it, and we've put loads of drops as well already. Now, this patient has been using drops because from her previous visits to the other specialist, and maybe if she didn't, the skin would be a lot more dry, and I'd be able to get a better grip on it. But because it's already this consistency, adding drops does help because it's already at this stage. So it would have been probably better for this patient to attend without using any drops initially. Now, moving forwards, however, I have just recommended this patient use drops on a regular basis, but once we've cleaned the ear, then it's a different composition. So when you've not got any wax or skin in the ear and you're using it on a regular basis, that will be beneficial. But once you've got the skin like this, then using the drops for me it's too late. But once you have used the drops, when it's like this, we need to then actually add fresh drops during the procedure to facilitate the removal. So again, started peeling that. It was going towards the eardrum and then it just cut away. It's almost some of this caramel skin, as I'm trying to peel it, I'm almost spreading it against the canal wall because of it's quite mushy. So just working back near the entrance of the ear canal. I want to lift some of this skin, see if I can peel it towards the eardrum. I think some of this skin peels backwards initially, you should see. Really trying to tug it up to separate it, and then I'm going to go forwards. But the skin is just trapped here to the right hand side, so although I'm trying to peel this forwards, because the skin also travels up the anterior canal wall, is just where I am here to the right of the suction probe. But I can just lift it a little bit more, I can loosen that tension of the skin in this region. I'm coming back to that. This is where this piece of skin is preventing me from peeling any further forwards. So I'm just going to the left of it now. You can see as I'm trying to peel that skin, I'm actually just pushing it down. And it is lifting back up again, but it's on occasions it was almost like I'm spreading the caramel skin again. So I'm going to this region, trying to peel some of this way to loosen it, I think. But we're so close to the anterior canal wall that as I'm lifting up, I could quite easily graze the front part of the ear canal. So again, you can see I'm doing these inward movements. So I've just put some more drops, and now that I've lifted some of that skin, I'm hoping some of the oil will seep underneath it and almost help break up that skin. The patient asked me for how would I best describe the skin. So I use the word caramel, but also glue. It is like glue. So after I put the drops, this piece of skin lifted up. So I've gone to the back part of the ear canal. And with the angle of the suction probe, I want the tip facing towards the eardrum. Otherwise, if I peel with the tip facing directly ahead, we're going to graze the canal. So the tip is almost pre-orientated. So as I move it away, it's going to move away from the ear canal as opposed to towards it. So some of the oil has seeped underneath here. So I'm just breaking this layer up and peeling back. But now that I've separated that piece of skin from skin that I just let go of. It should be easier now peeling forward, which you'll see. See, it's just the thinnest layer that, I mean, you wouldn't have even thought there was some skin there until I started peeling it. And now I can start going forwards. So initially I wasn't even aware that the skin even existed because it's so thin, so transparent. It looked like the underlayer of skin. I'm just trying to lift this up. So we're entering past the isthmus. So the ear canal narrows at this juncture. Around 0.5 centimetre away from the eardrum, most ear canals are narrowed and they widen again. As I was getting deeper, and you'll see how I overcame that issue. Obviously, when we go deeper in the ear, you're having to also insert the endoscope a bit deeper. And because this entrance was so narrow, although I was able to get both the endoscope and the instrument into the ear canal, they were in close proximity, which slightly restricted my movement with the suction probe. And with the suction probe, I need that movement to peel the skin. So what I did, in a moment you'll see it, I zoomed in using the app, the ClearWax app, and by zooming in just slightly, it means that I don't have to insert the endoscope any further than I was originally when I was removing the skin from the outer half, which then just frees up some space for me to maneuver my instrument. So this is not a procedure that I would attempt with the wax scope or even my ENT microscope. I think for this kind of procedure, the endoscope is far away the best, because when you're working so close to the ear canals, you have that field of view that you need to gently peel it away. Now, there's a little hole now in that skin, and at this point the patient actually noticed they could hear a bit better, and you might think that's a bit silly, but even opening up that little hole, some sound is now getting through. And because I can see that break in the skin, I've got a better idea of how thick this layer is, because I can see some of the eardrum behind it, and I'm more confident now approaching it. Before, I just wasn't aware how thick this was, and the last thing I want to do is bump into the ear canal. So that little hole there, not only has it improved the patient's hearing, but it's acting as a guide for me. Now the posterior canal wall is a bit wider. I don't know if you notice, you'll see it a bit more as I clear the ear. So there's a bit of a widening on the posterior canal wall. So I'm in the isthmus, this is the inferior recess. And I'm just holding the suction probe there. I want the suction power to lift this up. I suspect a lot of people may have turned away from the videos. It's not one of those traditional earwax removal which is really, really satisfying. This is more of a technical one, which kind of I enjoy. But I know they're not always the viewers' favourites, but I can appreciate that. Now, what's also great about with the new right ear canal suction tips and handles is that I've got the ability now to reorientate the angle of the suction probe that you're seeing on screen now against the handle, which means I can enter the ear at different angles and orientations. So when I'm working at the front part of the ear canal, I'm holding the suction probe differently to how I was for the beginning of the procedure. And that's only possible because with the right suction handles and suction tips, you can attach the suction tip at your preferred angle. With most common suction probes in the UK, the steel tube is pre-bonded to the handle, so your grip is limited in terms of how it's bonded together, and it's not always beneficial. Now this is where I've zoomed in. You can see on the screen, if you look on the outside, the perimeter, a lot more is cropped away because I've zoomed in, but by zooming in, it means that I don't have to insert the endoscope any further than I originally was, and it's giving me space to maneuver the instrument. Can't zoom in too much because then the view gets a bit pixelated. So we can see the bottom half of the eardrum. This northern hemisphere is still smothered in this caramel skin, glue-like skin. So I've got two options. On the top right, you can see some skin. I can go directly, I put some drops in. You can try and hover over the softer wax of the anterior recess to see if it comes away. Some of it did. And you've got that tail of skin on the back part of the ear canal still. So they're kind of three routes I could approach. I'm trying to avoid peeling from the top because at the moment anyway, because this skin layer is so, although it's very, very adhesive, it's really, really thin. And then to peel that off the canal wall, you just got to be so careful, because if you graze the top part of the ear canal in particular, it can be uncomfortable. Well, all the bony part can, but especially the top region. So I'm just going to widen the ear canal again. And because it was a narrow ear, it's not always, you can't see it on screen. Obviously all you can see on screen is, you can't see me working off the screen, but we had to get this patient's head in a certain angle. I was having to position myself slightly differently just to get access to this front part of the ear canal. Because the ear canal is not a straight cylindrical tube, there's bends and twists. So as I entered this patient's ear, imagine I'm stood outside this patient's ear canal. To make entrance, first of all, I would have to, imagine I'm walking in a straight line and stopping and then moving left and right. I would enter the ear at 1 o'clock, then pause, then I would have to sidestep to the left, so at 9 o'clock, a few paces, and then enter forwards again, and also then re-angle back to 1 o'clock. So you can see I'm going forwards at 1 o'clock, stopping, moving to the left, and then back forwards and to the right again to gain access. So there's quite a bend there, and because the ear canal is quite narrow, when you're inserting the instrument and working to the front part of the ear canal, this is where the change of grip really, really helped me. If I was holding it like a pen grip, like I typically do, I would have to angle my holding hand. I'd have to twist it quite a lot to again position the suction tip to the right. But with the thumb grip that I use when I'm working at the front part of the ear canal, that movement is somewhat mitigated. So my holding hand is in a more suitable and comfortable position as well. So it's more ergonomic. So we can see most of the eardrum, or we can see all the eardrum. There's just this layer of skin here now that's lining the posterior canal wall. This is where it's slightly widened. And then it's also coating the posterior superior quadrant of the eardrum, so the north, the west region. Now, I don't get all of it, but I managed to get most of it away. So this is where, again, you can just see how thin that layer of skin is. So I need to get the tip of the suction probe to kind of capture that and then peel down. It was frustrating at times because you did the difficult bit was actually managing to start to peel that off the canal wall, and then you're hoping once you have and you start peeling, the skin just loosens. But here it's not, it's just cutting away. It's starting to loosen from the top as well, so I'm just going for this portion here. I know some of you say, why don't you use the Corette here? I would never use the Corette here to peel this skin. It's just so in a sensitive region. I know some of the videos in the Far East, they use these instruments now. Their skin is completely different. It's dry skin. And also some of those patients, I believe, have had some anaesthetic as well. Not all of them, but some of them you can tell that they're... I think the people that perform the procedures also mention it as well. So I'm still zoomed in, which is working quite well. And again, it's going to change my grip just to angle the suction probe in this direction. See how stubborn it is. It just didn't want to come away. So I'm beginning to think now, when is the best time to start? But I wanted to see if I can get a bit more away, especially in this region, but I don't think I managed to do so, but we shall see. So we've got a bit off the eardrum directly, and there's a bit to the left. I think if I can start peeling this away, the rest of it will come away. But I don't know if you can see this region of the ear canal. It's a lot wider. It's almost like an opening here. Like it's eroded, probably remodeled. But normally you'll have bone in this region. And it could just be anatomically, this is what their patient's ear was like. Yeah, it wasn't really peeling from that region. I put loads of drops in already. I mean, the patient's been sat here for a long time, and I still had to do their left side. The left side was a bit more straightforward. I haven't uploaded it because this video is long enough, but that took me about 10 minutes as well. They had the same type of skin, but it wasn't near the eardrum. It was only the outer half of the ear canal, which didn't, and it was a bit drier, that skin. It was a bit easier to peel. So I'm just mopping up near the entrance. And I'm happy with that. So it's the patient. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.